Okay guys, the next topic that we shall be studying is MCQs related to metabolic acidosis. Let's start with the first one. It talks about a 47-year-old man with history of a heavy alcohol usage and 2-day history of severe abdominal pain, nausea and vomiting in the patient. When you read about alcohol and then you read about abdominal pain, obviously the first thing that comes to your mind would be possibility of acute pancreatitis in the patient. In this particular patient, he is mentioning that the blood pressure is on the lower side. Probably he is having a developmental distributive shock in the long run. The laboratory studies show a sodium of 132, a chloride of 92 and a bicarbonate of 16. So whenever you read information like that, you should quickly not waste time and at the same time evaluate the anion gap of the patient. So this would be a mathematical value of definitely a elevation. This would be approximately 24 milliequivalents and the normal is about 10 milliequivalents. So this guy is having a increased anion gap much more than normal value of 10. A room air blood gas is drawn and reveals a pH of 7.28. So this is a acidotic pH. There is a development of a low PCO2 of the patient. So low PCO2 cannot explain the acidotic pH of the patient. There is definitely a low bicarbonate in the patient, which explains the acidotic pH of this guy. So the primary change of this guy is presence of metabolic acidosis. I was thinking that this would be metabolic acidosis right in the first two lines of the question, because in any patient of pancreatitis, once you have development of shock distributive one, there could be a metabolic acidosis developing. In these patients, there will also be compensatory process going on. The compensation process will involve hyperventilation in the patient that will contribute to loss of carbon dioxide in the body. This guy is having a partially compensated metabolic acidosis having a respiratory component. What I imply by respiratory component is that the hyperventilation has resulted in washout of carbon dioxide of the patient. The final answer to this guy is HAGMA, that is high anion gap metabolic acidosis with partial compensation. Most of the questions of metabolic acidosis are relatively easy to solve. We can also calculate the mathematical rule here, that what is the expected level of PCO2 in this patient and compare with the actual PCO2. The mathematical rule for expected PCO2 is bicarbonate plus 15. The actual value of bicarbonate given in the question is 16, which will work out to a PCO2 of 31 millimeter, and in this particular question it is precisely 31 only. So you can see the fact that because expected carbon dioxide value is equal to the actual PCO2 values of the patient, this means the fact that the compensation process is working just fine. So why are we studying this, or why are we calculated this expected PCO2, is to check whether the compensation is occurring or not. Because if this mathematical formula would have not been satisfied in this question, then there could be a possibility of a combination of metabolic acidosis and respiratory acidosis in a patient as well. But because the formula is satisfied, that means there is no mixed disorder. It is just compensatory disorder which is given in this question. Answer to this question is HAGMA, high anion gap metabolic acidosis with a partial compensation. Coming to the next question, you can see that the patient is having an acidotic pH. pH is 7.27, that is definitely lesser. He is having a low PCO2. So I can say the fact that in this guy, low PCO2 cannot explain the acidotic pH. There is a low bicarbonate that can definitely explain the acidotic pH of the patient. So the primary change of this guy is metabolic acidosis. In all patients of metabolic acidosis, as I've highlighted, patient should always hyperventilate. Remember, small breathing is a method of compensation. The body is trying to remove carbon dioxide from the body so that you are having less proton generation. Due to this hyperventilation, the PCO2 in this patient is reduced. Therefore, I will say that because carbon dioxide is being kicked out from the body, compensation has kicked in. This would be a partially compensated metabolic acidosis developing in an individual. If in this question, hypothetically speaking, the value of PCO2 was given to be 38, then I'll definitely not say that this is partially compensated. Then my answer would have been that this chap is having uncompensated metabolic acidosis because the hyperventilation process has not started. Suppose in this question, the value of PCO2 was 60, keeping everything else same, then this patient will be having two things. He will anyway be having metabolic acidosis. Along with that, he will be having respiratory acidosis. Metabolic and respiratory acidosis will be a mixed disorder. So I've given 3 permutation combinations in this question by changing the value of PCO2 in the question and keeping the remaining values stable. The 3 answers to this question are partially compensated for the initial, the way the MCQ is. If PCO2 is normal means no compensation is working, and in combination disorder obviously there will be 2 reasons for acidosis, where because carbon dioxide is elevated, respiratory acidosis, and bicarbonate is less, it is metabolic acidosis. If you're wondering how the hell is this possible, it is possible in cardiorespiratory arrest. If you focus on cardiorespiratory arrest, cardiac arrest will cause circulatory failure, that will cause metabolic acidosis. And in respiratory arrest, the word is respiratory arrest, so it will cause buildup of carbon dioxide and respiratory acidosis. So do remember this fact, metabolic and respiratory acidosis together, that would be cardiorespiratory arrest developing in a patient. The answer to this question is partially compensated metabolic acidosis. Moving to the next question. You can see the fact that in this person, the values of PCO2 have turned out to be normal. The PCO2 of this patient is low. This means the fact that there is a carbon dioxide washout occurring from the patient. There is also a low bicarbonate value occurring in the patient. The low bicarbonate of the patient explains the fact that he is having metabolic acidosis. To compensate for this metabolic acidosis, this patient is also exhibiting a hyperventilation, and that hyperventilation is responsible for loss of carbon dioxide from the body. The compensatory process of metabolic acidosis is called as respiratory alkalosis. Because in this question pH of the patient is normal, you can see the fact that the 2 processes will counterbalance each other. Therefore, the first word that you will write for this chap would be fully compensated. Now, you have to understand the fact that what's the primary defect of the patient. The primary defect of the patient is metabolic acidosis. What is the primary change? It is low bicarbonate. Why I'm saying? Because that is how the sequence would evolve in the patient. The correct answer to this patient will be that the patient is having a fully compensated metabolic acidosis. The answer to this is A. The bicarbonate value has become relatively lesser in this particular patient, and therefore metabolic acidosis is explained, and then the low carbon dioxide explains the hyperventilation component. Choice number C is fully compensated respiratory acidosis. Now, why I'm ruling out fully compensated respiratory acidosis? Because the carbon dioxide should be elevated in the patient, and the remaining data anyway does not make sense because it's a fully compensated value. So answer is A to this particular question. In the next question, you can again see there is a acidotic pH in the patient, 7.23. The PCO2 of the patient is normal. So acidotic pH cannot be explained by normal PCO2. But there is a low bicarbonate patient in the patient. So the defect in this patient is that of metabolic acidosis. In all patients of metabolic acidosis, compensatory processes should start and hyperventilation should begin to kick out carbon dioxide from the system. In this fellow, carbon dioxide value is normal. That means till now the compensatory mechanisms have not kicked in. So this would be an uncompensated metabolic acidosis present in the patient. The basic thing that I'm repeating oft and again for all the questions that I've discussed with you is that if you work out it is metabolic acidosis, how do you know that? Bicarbonate should be low, pH should obviously be low. Just focus on the value of PaCO2 in the patient. If PCO2 is normal in the patient or it is less in the patient, your answers would be there. If it is normal, it is uncompensated. The hyperventilation process is not started. If it is lesser, then you are going to call it partially compensated metabolic acidosis in a patient. Suppose you get a question in which carbon dioxide is elevated, then it is definitely not a compensated disorder. It's a mixed disorder which will be having a combination of metabolic acidosis and respiratory acidosis in a patient. The answer to this question will be given as choice number C, metabolic acidosis uncompensated. Let's do another one. Patient is having a pH of 7.30. This tells you the fact that this is a acidotic pH. The PCO2 of the patient is normal. That means compensatory processes are not starting in the patient. Why I'm saying that is because bicarbonate is low in the patient. we have done this practice multiple times now, that in acidotic pH with a low bicarbonate, it is metabolic acidosis, and because the pH is normal, it is uncompensated, and if the value was lesser than this, then I will say it is partially compensated metabolic acidosis. The pH will normalize, it will become fully compensated. Let's do it one last time. A 8-month-old female baby was admitted with 1-day history of lethargy. The kid has vomited multiple times. Her drug addict mother, that's of interest, drug intake mother said that the baby looks intoxicated. So, well, she has exposed the baby to drugs maybe. The baby is obtunded but easily rousable. Muscle tone is normal. Respiratory rate is 60, a little faster for a child of that age. I would think it to be in 40s. Pupils are normal, so there is no opioids that we are talking about. There is no evidence of dehydration, that's good. Blood pressure is fine. Heart chest examination is normal. Planters are normal. So the good news is that the baby is having only tachypnea. Though pupils are normal, that means at least the CNS part is not depressed in this child. Sodium is 135 and the chloride values are 116. Bicarbonate is 6. So let's quickly calculate the anion gap of this particular patient. And you can see the fact that this would be something in the range of 13 millicoulombs, which is more than average of 10. So yeah, the anion gap of the patient is increased. In the urine analysis, pH is 5, okay, acidotic. Maybe the child could have been fed. Negative for glucose ketones, so no ketoacidosis. Calcium oxalate crystals, that gives you a clear hint that this is probably antifreeze ingestion. Antifreeze would be ethylene glycol poisoning in the patient. So remember the fact that ethylene glycol poisoning is a manifestation that is encountered with antifreeze. In these patients, you will notice the fact that there is a acidotic pH explained by the fact that there is a acute tubular necrosis in process in the patient, so kidney is failing. Bicarbonate is low, that means the hyperventilation process has been kick-started, and bicarbonate in the patient is also significantly low, so there is a metabolic acidosis present in the patient. This particular patient is having metabolic acidosis due to ingestion of antifreeze agent. Remember the mnemonic cult, that is ketoacidosis, uremia, lactic acidosis and toxin, so this is the toxin component. And since in this patient the value of carbon dioxide has been reduced, it means that the hyperventilation is the compensatory process. This patient is definitely fighting for her life. She is having partially compensated metabolic acidosis. Maybe I might be requiring to give her a soda bicarbonate shot, and subsequently I will anyway have to put this child on dialysis because of the high risk of acute tubular necrosis. The patient is having a partially compensated metabolic acidosis. We can definitely stabilize the patient at this particular juncture by giving to the patient soda bicarbonate, but then it will not be very productive in the long run, because if the urine output of this patient tends to reduce in the next coming hours, there's a possibility that she goes into ATN, and therefore there would be potential necrosis in the kidney of the patient, which I don't want to take. So most of the time the questions would tell you regarding the diagnosis. When I read this question in the first line, I was under impression that the question could be of opioid poisoning and there would be a respiratory acidosis in the patient. But then he just turned the tables by saying that the pupils are normal in the patient, there's fast breathing, that's the hyperventilation component kicking in, and calcium oxalate crystals, that is the antifreeze ingestion of the patient. We will now be doing questions of metabolic alkalosis. Mr. Sharma, who underwent a post-abdominal surgery, has a nasogastric tube in situ. A nurse on duty notes that it is draining large amounts of coffee ground secretion. So there could be possibly blood which has decomposed, or rather I would say the blood has been degenerated by the acid in the stomach, contributing to acid hematin formation, which is coffee ground in color. Patient is not conscious oriented to time, space and persons who did a stat ABG, and this will show presence of alkalotic pH. In alkalotic pH, the value of carbon dioxide is normal. So normal PCO2 cannot explain alkalotic pH of the patient, but there is definitely a elevated bicarb value of the patient, which explains that this patient is having metabolic alkalosis. In all patients having metabolic alkalosis, the carbon dioxide values should rise. Patient should develop a compensatory process, which is respiratory acidosis. So carbon dioxide is expected to rise in this condition. Remember my statements. In all patients having metabolic acidosis, there should be a hyperventilation that should cause a carbon dioxide to decrease. Whereas in all cases of metabolic alkalosis, the compensatory processes will be respiration will slow down and carbon dioxide will tend to increase. In this case, carbon dioxide should increase, but it has not increased at the moment. It is normal. So the diagnosis of this chap would be given as uncompensated metabolic alkalosis present in this patient. The reason for this uncompensated metabolic alkalosis is dehydration because of the nasogastric tube in situ, which is draining large amount of fluids. There's a possibility that this patient could be having a presence of post-operative ileus. There is a hemorrhagic gastritis due to stress. Due to dehydration, the GFR of the patient is less. The RAS will be activated. There will be an upgrade of aldosterone in the body, and the upgrade of aldosterone in the body will contribute to urinary loss of potassium and hydrogen. So this patient will be having a hypokalemia because of urinary loss of potassium and metabolic alkalosis due to urinary loss of hydrogen. The correct answer to this question has already been told to you, but I've tried to explain to you the fact that whenever you read about excessive NG tube drainage, then you have to think in terms of hypokalemic alkalosis present in a patient. If they ask you to calculate the expected PCO2 of this particular patient, then the formula to be used is same as that for metabolic acidosis. The expected PCO2 of the patient is 15 plus the value of bicarb. The value of bicarbonate in this patient is 30. So expected PCO2 of this patient is 45 millimeters of mercury. Now look at the value. The actual value is only 37. This explains the fact that the compensation process has not started in the patient because I expect the PCO to be 45 and the actual value of the patient is only 37. So whenever you are having expected PCO2 matching with the actual value, that means compensation is perfect. But if the expected PCO2 of the patient is not present in the patient, in a sense that PCO2 is still normal in the patient, then it is uncompensated. And on the other hand, if I say the values turn out to be higher, then it could be a mixed disorder. It could be combination of metabolic alkalosis with respiratory alkalosis developing in a patient. I mean, I'll talk about the mixed disorder subsequently. But at the moment, what I want to say is that since in these patients the values of PCO2 are normal, the compensatory process has not started. Let's take up the next one. Okay guys, in this particular question, that is question number 21, you can see the fact that the pH of the patient is slightly on the higher side. So this is a alkalotic pH. The PCO2 of the patient is elevated. So elevated PCO2 cannot explain the alkalotic pH of this fellow because elevated PCO2, as we have discussed, causes respiratory acidosis. The bicarbonate of this patient is slightly elevated, so I would say the fact that it is the elevated bicarbonate that is explaining the primary problem of this patient, that the patient is having a metabolic alkalosis. In all patients of metabolic alkalosis, the value of carbon dioxide in the body should begin to rise. This carbon dioxide will begin to rise since the patient will be having a compensatory process by the name of respiratory acidosis. Since in this patient PCO2 is slightly elevated, that means compensation process has occurred. Therefore, this patient will be answered as having a partially compensated metabolic alkalosis. That would be choice number D in this particular question. Remember the fact that if in this question PCO2 was given to be normal, let me say the PCO2 of this patient was given to be 40, then I would say that this patient is having a uncompensated metabolic alkalosis. As I said in the previous slide, I'm repeating that again. In metabolic acidosis, the carbon dioxide values should fall, and in metabolic alkalosis, the carbon dioxide values should increase. Let's do some mathematics here. Predicted carbon dioxide values for the patient. The formula is same as that for metabolic acidosis, that is bicarbonate value plus 15. The predicted PCO2 of this patient should be 28 plus 15, that will work out to a value of 43. But you can see the fact that the predicted value is in this patient is not being met. That tells you the fact that in this particular patient the compensation process is occurring, but it is rather slightly elevated in the patient than what it should be. So either it could be a factual error, or the body has adjusted in a fashion that the value is higher. You see, what I'm saying is, if this predicted PCO2 value was not met, if it was not met, then I would say lower side, then I would say the fact that the compensation process has not occurred uncompensated in this fellow, because it is being met, so it is partially compensated. And very soon, considering that the PCO2 is high, we will see that the pH of this patient will stabilize, so he is on the road to recovery. He's definitely gonna make it, since the compensatory processes are kicking in. The answer to this question is D. You are reviewing the latest ABG report from a sick Cushing syndrome patient. In Cushing syndrome, you should be aware of the fact that cortisol is elevated, and elevated cortisol will contribute to stimulation of the epithelial sodium channel, which will contribute to more sodium and water coming in. But at the same time, in the patient, there will be a corresponding loss of potassium and hydrogen. So hypokalemic alkalosis could be developing in this particular patient. The question says which indicates that the ABG derangement is compensated. So step 1 is that he expects you to know that Cushing syndrome patients are said to be having, or are expected to be having, metabolic alkalosis. In metabolic alkalosis, the compensation process is carbon dioxide values should rise, because compensatory process of metabolic alkalosis is respiratory acidosis. So I expect the carbon dioxide to rise. So out of the 4 changes which are given in the question, PCO2 elevation more than 45 is the one that is expecting as an answer. I mean, this is actually a 2-step question, I would say, guys. One, he expects you to know what is the derangement, and second, he wants you to know that what is the compensation of it. So I think it's a 2-step process, not too much of effort to do in the final exam. Answer to 22 is D. A patient is post-op from knee surgery. He has been receiving analgesia 4 milligram IV every 2 hours. You notice that he is exhibiting a respiratory rate of only 8. So post-operative knee surgery patient, respiratory rate of 8, that is definitely respiratory depression. He is drowsy also, so there is a possible risk of carbon dioxide narcosis in the patient. I have emphasized this often again, that drugs contribute to CNS depression, and therefore in this particular patient, the derangement that will be encountered will be carbon dioxide narcosis. If this question was mentioned as, suppose I change this question as, the patient is having an inadequate analgesia because of the pain, the patient will tend to hyperventilate. Hyperventilation will contribute to carbon dioxide washout, and the same patient will then be having respiratory alkalosis. So the question can be twisted in any way, the way the examiner wants. The basic concept is post-op patients can either be having respiratory acidosis or can be having respiratory alkalosis, depending upon the situation given in the question. If it is overdosage of CNS depressant drugs, it is respiratory acidosis. If it is inadequate analgesia, it is a respiratory alkalosis in the patient. In the next question, we'll talk about multiple other ABG scenarios, but this time what I'll do is that I'll make you practice without any prompts. The question says a patient, I'll not mention in this case whether it's metabolic acidosis or alkalosis in advance, we'll simply evaluate. A patient tried to commit suicide by ingesting a bottle of aspirin. You can see that, the question has been created only for the heck of it, because, nobody will try to commit suicide with aspirin. Anyway, crazy chap is trying to do suicide with aspirin. There will be development of acidosis in the patient because acetyl salicylic acid will accumulate in the body. Acetyl salicylic acid is a potent stimulus of the respiratory center, because of which this patient will exhibit hyperventilation and carbon dioxide washout will occur in the patient. The derangement that will occur in this patient will be metabolic acidosis with development of respiratory alkalosis in a patient. The question, however, says what condition is he at risk for? Then I want you to remember the fact that respiratory alkalosis and carbon dioxide depletion in the body causes intracellular shift of ions. The ions that tend to move in are sodium, potassium and phosphate. So these products will become lesser in the body of this patient. You will also remember that in this particular patient's respiratory alkalosis, there will be increased protein binding. This increased protein binding will be for calcium. As a result of it in this patient, the value of ionized calcium will tend to reduce, and therefore tetany can be developing in the patient. Choice A is ruled out in this question because it would be hypokalemia. Choice B is ruled out because there would be tetany, that is hypocalcemia. From the remaining two options, I wanted to remember that because the patient will be having hyperventilation, there will be a development of respiratory alkalosis developing in this case. So the message is that carbon dioxide depletion is dangerous, carbon dioxide accumulation is dangerous. In fact, carbon dioxide depletion predisposes to development of tetany in the patient. Respiratory alkalosis can affect which electrolyte levels in the body? As I just explained to you, it will affect the values of calcium and potassium, and what will happen to both of them? Both will become lesser. Tetany and hypokalemia can be associated with carbon dioxide depletion from the body. This explains the fact that why you couldn't read about arrhythmias developing in respiratory alkalosis. Harrison has not given any particular reason for why is there a fluid shift occurring in the patient, but as a clinician, I'll be more interested in what is the manifestation in the patient. There are a lot of things which in medical science might actually remain unexplained. This is one such demonstration of that CO2 values enhance the protein binding and they tend to reduce. There's a physiological basis behind that obviously, but to elucidate that, there is no concrete evidence given in at least clinical medicine books for that. I looked up Genong for that also. It does not give any clear description for what are the steps that would contribute to manifestations. For metabolic alkalosis, it is very clear. You can listen to the metabolic alkalosis leading to tetany in the section of the kidney where I've spoken about it, but he does not mention why tetany develops in respiratory alkalosis, except for what I just told you, that the protein binding will enhance with albumin and therefore ionized calcium will become lesser. The answer to this is C. A patient is experiencing respiratory alkalosis. What is the classical sign seen? The sign of tetany would be Chvostek sign developing in the patient. There would be stridor in the patient. Well, what is Hoover sign? Hoover sign is something that you are going to be encountering from neurological perspective. Here the patient will be having, the patient says that he is having leg weakness, and to demonstrate this patient from a hysterical patient who is complaining of leg weakness, you will ask the patient to raise his one leg and you will be supporting the other leg with your hand. If a person is having a genuine weakness, then what the person will do is that when he is raising one leg, he will try to take the support with help of your other hand. He will try to push down on your contralateral hand so that he can raise one leg. He'll try to use one hand of yours for traction purposes. But I'll say like this is evaluating genuine leg weakness versus a hysterical leg weakness in a person. That is, a Hoover sign can be seen in the patient. A patient is experiencing respiratory alkalosis. He says, what is the most classical sign seen in this guy? So as I've explained to you, respiratory alkalosis will contribute to development of tetany in the patient due to increased binding of calcium to albumin in settings of respiratory alkalosis. This tetany will contribute to Chvostek sign developing in the patient. There would also be stridor and laryngospasm that will contribute to mortality in the patient. ECG finding of tetany should be remembered as prolonged QT interval. You will definitely not get a significant bradycardia in respiratory alkalosis. So initially I thought it could be mainly a question related to bradycardia as a manifestation because of QT prolongation, but the more appropriate answer for this would be Chvostek sign. A patient is having the following blood gases with a pH of 7.50. Even if PCO2 is given first in the question, you should avoid raising PCO2 because you will tend to get a bias. First read pH, and that would be an alkalotic pH present in the patient. Now, considering that he is having an alkalotic pH, in this particular patient, you are noticing that there is a low PCO2. So, one etiology that could be explaining this could be he could be having a respiratory alkalosis. Low bicarbonate cannot explain the alkalotic pH of the patient because low bicarbonate causes metabolic acidosis. So, the main problem in this guy is that there is a respiratory alkalosis which is causing a carbon dioxide washout from the body, and therefore there is a alkalotic pH developing in the patient. The compensation of respiratory alkalosis is metabolic acidosis. That is why in this patient bicarbonate is low. So this particular chap is having a partially compensated respiratory alkalosis. The question says which of the following could not be a cause of this condition. So anxiety will cause hyperventilation and will contribute to loss of carbon dioxide from the body, and therefore there would be respiratory alkalosis. Hysteria will also have increase of respiratory rate, so there will be carbon dioxide washout from the body causing respiratory alkalosis. Aspirin toxicity will stimulate the respiratory center of this patient and increase the respiratory rate of this particular patient. The basic point is that you can solve this question by exclusion, because choice A, C, D will cause increase of respiratory rate. The answer to this will be B, that is severe ARDS. In patients who are having ARDS, the value should be less than 300. If it is going to less than 100, you will notice that the patient will be having severe hypoxia that will even cause constriction of the pulmonary vessels. Due to constriction of the pulmonary vessels in the patient, there will be a buildup of carbon dioxide in the patient. So in ARDS patients, initially when the patient comes to you, you would be having a respiratory alkalosis, but as the hypoxia worsens due to collapse of the alveoli, you would then be having a respiratory acidosis and buildup, because the blood vessels around the alveoli will begin to collapse or they'll constrict because of the hypoxia component. The buildup of carbon dioxide will contribute to respiratory acidosis in the later stages of ARDS, that is the severe variety. Answer to this question is B. A patient on mechanical ventilation is having the following changes. Even if he gives you the PCO2 in first and then pH, first read the pH. This is an alkalotic pH once again. This patient is having a low PCO2. So this tells you fact that low PCO2 could be explaining the alkalotic component. Let us look at bicarbonate. The bicarb value of this patient is normal. This means the fact that in this person there is a respiratory alkalosis developing in a patient. There's a hyperventilation going on due to mechanical ventilation, so is losing carbon dioxide. But at the moment the bicarbonate values have not begun to reduce. So therefore in this fellow there will be an uncompensated respiratory alkalosis present in a patient. Remember, I taught you in respiratory alkalosis, for every 10 millimeter fall of value of carbon dioxide, here it's falling by almost 20 points, you should be having at least a 2-point fall in the value of bicarbonate, and that has actually not happened. Remember, 24 was the formula for acute, 2 for acute, 4 for chronic. So this fellow is having an uncompensated respiratory alkalosis. The answer to this question is A. Most mechanically ventilated patients will be having respiratory alkalosis, and respiratory alkalosis will always be having in fact it is one of the commonest ABG derangements in chronically sick patients in your ICU. A patient is experiencing respiratory acidosis due to brain trauma. Which of the following lab values will correlate with this acid imbalance? I have explained to you the fact that respiratory alkalosis contributes to intracellular shift of ions like sodium, potassium and phosphate. So in patients who are having respiratory alkalosis, you could be having a hyponatremia, hypokalemia and hypophosphatemia. Reverse is true for respiratory acidosis, where these will start coming out of the cells into the blood, and when they'll come out into the blood, the values can increase. So here all the 4 options are on potassium. So all you need to remember is respiratory alkalosis and carbon dioxide depletion causes potassium to fall. You'll remember it like this: when carbon dioxide falls, potassium values also begin to fall. The reverse is also true. If carbon dioxide begins to rise, potassium starts to rise. The answer to this question is A. You have to solve some questions on basis of what you know, and then you need to apply opposite of that. This is one such question, very atypical one, but then that's how things are in the question, in the paper. Which of the following patient is experiencing partially compensated respiratory acidosis? So I will first look at in which questions pH values are normal. 7.35 is normal, so at least one choice is immediately ruled out because this is fully compensated. So I will have to select from the remaining options. Even C I am ruling out. Why? Because there is alkalosis given in this question, whereas the question is asking me regarding acidosis. Now there are 2 options which are left before me, so let me evaluate. In choice number B, there is definitely a pH that is low, so there is a acidotic pH. Along with this acidotic pH, there is a presence of elevated CO2. So this looks like to be the answer, but let me just complete it. The bicarbonate of the patient is also elevated, so that means the compensatory processes are kicking in. The kidneys are trying to reabsorb the necessary bicarbonate, and bicarb values are in excess of normal by 2 points. In this particular case, yeah, he's having acidosis. In this patient, there is a elevated CO2, so that definitely tells me that the patient is having presence of respiratory acidosis. But the problem in this chap is that the bicarbonate values are normal. Because of the normal values of bicarbonate, I will have to prefix the word here uncompensated respiratory acidosis. Considering the scenario, the correct answer to this question will be given as B, where you are having a partially compensated because D is a choice of uncompensated respiratory acidosis in a patient. Answer to the question is B. Which of the following is not a cause of respiratory acidosis? In all patients having respiratory acidosis, there should be a buildup of carbon dioxide in the body. In patients having pulmonary embolism because of ventilation perfusion imbalance, there will be a development of carbon dioxide buildup. In patients who are having asthma of the severe variety, I'll say there's a flaw in the wording of this question. Choice number B should ideally say the word severe, even if it does not say asthma exacerbation can be severe to cause carbon dioxide narcosis. So is the case with COPD exacerbation that can contribute to carbon dioxide narcosis. The answer to this question is where hyperventilation will never ever contribute to development of respiratory acidosis. It will always cause a carbon dioxide washout, less protons being generated, so it will always cause development of respiratory alkalosis. Answer to this question is delta. The remaining choices can contribute to carbon dioxide narcosis, but D is always going to cause a depletion. A patient with COPD is having the following blood gases. The pH of this patient is 7.26, so he is having an acidotic pH. The values of PCO2 are elevated, so that explains the fact that probably he is having a respiratory acidosis present in him. If I look at the value of bicarbonate in this fellow, then bicarbonate is also elevated. This tells me the fact that this guy is having compensatory mechanisms kicking in because the kidney is trying to reabsorb the value of bicarbonate. The correct answer to this question is obviously respiratory acidosis. I will call it partially compensated because the PCO2 is not normal, the values of pH is not normal. Partially compensated respiratory acidosis is the diagnosis for this particular question. Moving to the next one, mixed disorders. This is the one that you really need to be least bothered about because it's very in your face. A 28-year-old lady was admitted to high dependency unit following a cesarean section. Diagnosis of fatty liver or pregnancy has been made pre-operatively, and she maybe is having right upper quadrant pain, so they put her on a morphine infusion. Since she is post-operative, so post-operative pain, and even for right upper quadrant discomfort, you can give morphine infusion. And well, she's very drowsy the next day, so is himself telling you there's a respiratory acidosis developing in a patient. This guy is having a acidotic pH. There is a elevated CO2 in the patient. That explains that this could be due to respiratory etiology. Look at the value of bicarbonate in this guy. I've explained to you the fact that when it comes to respiratory acidosis, the bicarbonate value should increase. It can be normal. It is uncompensated. If it increases, it is going to be a development of a partially compensated scenario. But in this guy, the bicarbonate value is low. So there is two types of acidosis developing in a patient. This is definitely respiratory acidosis, but then the combination of low bicarbonate with low pH means that there is also a metabolic acidosis developing in the patient. This is a mixed disorder. Let me give you mathematical direction for it. In all cases who are suffering from metabolic acidosis, let me say, we can go like this. If the patient is having metabolic acidosis, then the value of expected PCO2 of the patient should be the value of bicarbonate plus 15. If I put in the value of bicarbonate for this guy, mathematically speaking, in round figure it should be 36, but you can see the fact that the mathematical rule is not getting satisfied. The expected PCO2 of the patient should be 36, but you can see in this guy this mathematical rule is definitely not satisfied, so we will say that the compensation process is not occurring in this patient. This is an example of a mixed disorder. Most of the questions that you will get on the mixed disorder will be based on the kind of mathematical aspects I've highlighted before you. In case you're losing track of this, I'll highlight the core features once again so that you can just get a knack of it. If you get a question in which pH is, let me say, less 7.2, PCO2 is, for example, 60, so this is respiratory acidosis. Bicarbonate values are normal, that means it is uncompensated respiratory acidosis. Same question. Everything kept the same, but there is an increase of bicarbonate, so partially compensated. Look at the next one. In this particular patient, the patient is having bicarbonate only 10. In the last report that I've said here before you, this will be combination of respiratory acidosis plus metabolic acidosis. The second report is partially compensated respiratory acidosis. Why? Because bicarbonate values have increased. And the first value that I mentioned before you is uncompensated respiratory acidosis in a patient. Do practice these questions and this will become second nature for you. You don't really need to be bothered because he's himself telling you, morphine infusion, and even if he gives you mathematical, I think mathematics in this topic is relatively easier than the theory component. In the next question, you are having an acidotic pH. There is an elevated PCO2 in the patient, so probably the respiratory component is kicking in. The bicarbonate value of this patient is low. As you can see, the value of bicarbonate should be increasing. Here it is low, so I'll say this is again a mixed disorder. This guy is having a combination of metabolic acidosis with respiratory acidosis. I'm writing the word MA and RA, metabolic and respiratory acidosis. Both are coexisting in a single patient. When there is a mixed disorder, then we don't get into what is a primary or a secondary change. It is only for compensation that you need to work out the primary versus the secondary change in the patient. Let's do it one more time. A 70-year-old man was admitted with severe congestive cardiac failure. He has been unwell for a week. A 70-year-old man was admitted with severe congestive cardiac failure and has been unwell for a week and has been vomiting for past 5 days. Vomiting tells you there could be a metabolic alkalosis in the patient. Why metabolic alkalosis? Because dehydration, the RAS system would kick in and the aldosterone which is elevated will cause a urinary loss of potassium hydrogen. He is hyperventilating also and is distressed because of that, so there could be a respiratory alkalosis component in the patient. In this particular patient, if I try to calculate the anion gap, it would be sodium minus the value of chloride which is 79 and bicarbonate which is 20. So if I look at it mathematically, this would be a value of definitely much more than normal. Pardon, my mathematics is really bad. So this would be something in the range of 28 millicoulomb, which is much higher than the average value of 10. So anion gap is definitely elevated in the patient. In this particular case, you are also noticing the fact that there is a alkalotic pH of the patient. There is a low carbon dioxide in the patient, so this tells you the fact that possibly the respiratory component is there. In all patients who are having respiratory alkalosis, there should be a metabolic acidosis in the patient and bicarbonate should become lesser. But look at the value of bicarbonate of this guy. The bicarbonate of this patient is also elevated. So you can see in the equation that this guy is having a combination of respiratory alkalosis plus a presence of metabolic alkalosis present in this guy. I'll just trouble you by saying that this could also be a triple acid base disorder. Why I'm saying triple acid base disorder? Because anion gap is elevated in the patient, so there is some unmeasured anions in the body of this patient. A lot of patients who are having a presence of congestive heart failure can also develop under perfusion of tissues, and under perfusion of tissues can contribute to lactic acidosis also present in this patient. I'll not trouble you by going into triple acid base disorders, but I just want to highlight the fact that this anion gap, why is it elevated, is because there is a concomitant possible lactic acidosis also present in this patient, for which what will you do? Serum lactate levels. You can even measure the values of beta hydroxybutyrate, because if suppose this is a diabetic patient, he could be having a ketone body production in his body also, since he's ill. The main focus is in all patients of respiratory alkalosis, you should always be having a value of bicarbonate that should become relatively lesser, there should be urinary loss of bicarbonate, as I've explained in the earlier part. Here, surprisingly, the bicarb values are elevated, so that does not talk about compensation. This is a mixed disorder in this patient. The answer for this is plus, and therefore there is no rule of any primary workout to be done for this patient. So do go through these questions, guys, just quickly, and then practice them. And if you have any issues, you're most welcome anyway on the app or at my email marvamedicine@gmail.com. You can drop me a mail and I'll be glad to assist you for working out these questions. Thank you so much.